The broadcast is live.
Okay, welcome everybody to today's meeting. I'm Wendy Williams. I am the Deputy Lay Chair, and I'm temporarily opening this meeting while we wait for our chair to arrive. He's got some technical difficulties, so apologies for our late start, but we will start the formal meeting and hope that Andrew will be able to join us in the next few seconds. So if there's a slight discontinuity, apologies for that. Okay, so we'll start the formal side of the meeting with welcoming everybody to today, an important meeting today, and I'm sure that all of those who are joining us externally are attending with interest, and we hope we can answer a lot of your questions and also bring some interesting information for you too. Have we any apologies?
Yes, Dr. Fiona McGregor-Smith, Pam Smith, Dr. Matt Tyrer and Ian Ashworth.
Okay, thank you for that. Declarations of interest. Has anybody here got any declarations of interest of anything that is on the agenda? Okay, I'll take silence to mean that no one has. Thank you for that. So we'll start and go straight into the minutes of the previous meetings. If we have a look at those minutes, you've all got copies of them, and I'm going to assume that you've actually had the opportunity to read those through thoroughly. Did we have any written queries sent in prior to the meeting on those minutes? No? Okay, so quickly. Yes, sorry, Paula.
I sent a couple of comments through to Christine, albeit belatedly, with just a small number of comments in the section of the minutes where we discussed Weston Park. In relation to the minutes on the 7th of January. It was just to let you know that I'd sent those through.
Okay, so would you like to highlight those? It might be worthwhile you doing that now you've raised them. Paula?
So I've made a point about the word that we'd use the word amenable when we were talking about engaging with the care sector. And I'd asked that we change the word amenable because actually we're engaging with all of the care sector. And I just felt that that was a word that should be changed really and didn't reflect some of the discussion that we had. And I also made a couple of there's a couple of typo accuracy. For example, there was the word then instead of the word then. So I don't believe it materially substantially changes the minutes, but it was particularly around the word amenable when I sent through a comment.
Okay, thank you for that. It is important that we get the right flavour and so that it is completely understandable to anyone reading those public meetings minutes. Any other comments at all on the minutes?
Wendy?
Yes?
Hi, it's Suzanne. I had a couple of comments which I've sent in. They were regarding the health inequality report, where some of my comments hadn't been captured in the minutes. So I've fed those back to Christine as well.
Okay, would you like to talk about them or are you happy that Christine will incorporate them?
I'm happy that Christine will incorporate them, that's fine.
Okay, thank you for that. Any other comments at all? I'm just hurrying through those minutes. No? Okay, well, thank you for that. So we'll accept those minutes as a true and accurate record of our previous meeting. So if we now move on to our sorry, I'm just scrolling through, apologies for that. We move on to our action points. Were there action points on this one? Anybody has any comments on? Here we go, the action log. First one is ongoing, and that one is the road mapping on the update report regarding the ICP. Who is going to pick that one up and talk to that? Is that you, Tracy?
Yes, Wendy, I'm happy to cover that. So I'm Tracy Cole, Director of Strategy and Partnerships. It's ongoing. I think that there is some commentary within the Accountable Officers report that also refers to this action. We have full intention to continue this work, but at the moment it is paused along with many other aspects of our work in light of system pressure and COVID. And that's something that's been agreed with both of our integrated care partnerships. So in due course, we will be bringing something back, but it's quite right that that's stated as ongoing at the moment, Wendy.
Okay, thank you, because this is a fairly important area of work, but and we do have committees that meet up and in February, which will actually be looking hopefully at some of this as well.
Yes, sorry, Wendy, that is our intention, yes, and we would have had this back here, and we were planning to do so in November, but the request has come from our ICPs as well as from NHS England that we pause any non-essential activity, and so the intent and the commitment and the strategic objectives that we all agreed and the intention remains. It's merely a paused approach to take account of system pressure and the COVID response that's required.
Yeah, and I'm sure everybody agrees with that, Tracy, so thank you for that. Okay, so if we leave that as ongoing, 19, which is the finance update. Linda, I'm presuming that you're going to pick that one up and just tell us, update us on that one.
Yeah, so we did originally have a discussion. I had a discussion with Andrew and Claire, and we went through how we were going to go forward on this. But since then, obviously, we've had further information that nationally the financial framework is going to be in place for Q1, quarter one for 21-22. This means that moving this forward is quite difficult because we're waiting for some national guidance around how this will work going forward. However, we are still working together with our colleagues, my colleagues in the other organisations in Cheshire, both in the local authority and in the NHS, to look to see how we would move place-based budgets forward, etc. So we're working on that in the background while awaiting more national information. So when we can do something further, we will do it, but at the moment we're a bit just awaiting further information nationally. Okay, do we know when we're expecting that information? I am having, there's a meeting this afternoon, which is a national Teams meeting. So I'm hoping to get some more information on the timeframes and exactly what's going to happen at that meeting. Okay, thank you for that. So it's imminent. Yeah. Okay, item 26 has been completed. So 21, the committee governance review. And I think, Matthew, if we go directly to you on that one. Is Matthew around? No, Matthew's.
Hey, Wendy, I'm back.
Oh, there you are.
Sorry, I am listening in. Yeah, so again, this is something we're intending to bring a bit of an update to the next governing body. As we've not had any committee meetings, we've not had opportunity to take things through Governance and Audit Committee, but I will look to give you an update, especially outstanding action around the performance side of things. But as a lot of the actions and recommendations were discussed and covered at the last sort of meeting, that they are in place or in trail as we speak, but the performance bit is the bit we need to focus on. I'll be able to bring a further update at the next meeting.
Yeah, these are really important. The 3 points that we've just discussed are really important, but I think it's very understandable that with the tremendous focus on COVID response and everything else that's going on, these are just slowing down slightly but not being forgotten. So thank you for those updates. I didn't confirm the minutes of our extraordinary meeting, which I skipped over to look at the actual additional pieces of information. So can we just actually now just scroll back slightly and look at those minutes of the extraordinary meeting? Are there any comments at all that anybody's got to make on those?
Wendy, the points that I was making were related actually to the 7th of January. So that was a set of minutes against which I was remarking.
Okay, thank you for that, Paula. So we'll make sure that those are allocated to that particular minute group. So if there are none of those, we'll accept those as a true and accurate record for governance purposes. So thank you for that. Okay, we'll move on. and we'll go to the first item, which is our Accountable Officers Report. Claire is unable to be with us today. Oh, I can see our chair's arrived. Brilliant. Andrew, I will hand the reins back to you. And we're just about to start the Accountable Officers Report, and Tracy has kindly agreed to do that as Claire has had to give her apologies.
Thank you very much. My apologies for joining you late. Slight technical problems. I couldn't get through the link. I managed to get it to work. So my apologies. If you've introduced yourself, my name's Andrew Wilson. I'm the chair of the CCG. And thank you for Wendy for taking over at short notice. And I think we're about to hand over the AO's report. Claire has just had to give apologies. So Tracy, can we hand over to you, please? Thank you.
Yes, thank you. So I know Claire would have liked to have been here and delivered this herself. So in her absence, I will try and take you through a few salient points, and then I'm sure you'll have some questions and comments. I'm going to assume you've read the report. It starts on page 16 within the pack. There are around 5 things that I think are worth drawing your attention to in particular. Some things that are not written in the report I think are worth saying is that we are working in a way that we've never worked before, which goes without saying, but I would like to just comment on the system working, the system partnership that we're seeing on all aspects of the work within that report. I think that we are seeing across our 2 Cheshire places coming together and an integrated approach to deal with unprecedented times in a way that none of us have ever known before. So I think it's just worth acknowledging and thanking our partners within that. So the things to really draw your attention to that I think are particularly important are the NHS England improvement letter, which has asked us to focus on 5 priority orders. And that really is dominating the way that we're working at the moment. And behind that is a backdrop of extreme pressure across our health and care systems. So there's a great deal of focus on acute trust and discharging from hospitals, which is mentioned in there. But it goes without saying that that is also heat that is being felt within primary care, community care, mental health services. It's across our system that we're feeling that extreme pressure, and so the support is being looked at across the system as to how we can deal with those unprecedented levels of demand. There has been a response sent from the CCG in response to the integrated care system, the proposals that have been put forward nationally and to our local integrated care system, and that's available to be read there. So I think that's been penned but considered by a range of people within the CCG. And I think the other thing that is really important that we pay special attention to is the Ockenden review. This is an independent review that took place for Shrewsbury and Telford Hospital NHS Trust of their maternity services between the period 2000 and 2019. It's a difficult report to read, but it's important that it is read and understood and that we learn from it. So thanks to other colleagues who've also been involved. You can see from that that we have discharged our duties to ensure that we hold to account our local providers, that they implement the learning which has come from that report. And I think we can be very pleased again as a system that all have taken that on board with the importance that it requires, so that we've got the assurance that those things could not be repeated. So I will close there. I'm sure that there will be lots more that people want to question and comment on, and I will draw in my other exec colleagues to help with any questions that you want to pose. But I'm sure Claire would want to bring in other things, but hopefully that gives you a good summary.
Thank you very much, Tracy, and thank you for doing that at the last minute. Colleagues, do we have any questions or queries on the AO's report? So Suzanne.
Thanks, Chair. Stan Horrell, lay member for governance. Just a quick query. I don't know whether it's Linda on this one, actually, on CHC. I did drop a note just to ask. We've been asked to defer the assessments, which I realise is now a regional request. I'm just wondering whether there's any financial impact, because I know we were given quite strict time parameters to turn things around. Otherwise, we were at risk of incurring additional charges as a CCG. Or are they being waived because that was a national scheme rather than a regional one?
Okay, so Linda Riss, Director of Finance. In terms of the assessments, I suppose it's going to have so probably a couple of effects, but the first one being that the people will not be assessed. So they will remain in category 1, which means they will remain funded by the healthcare at the hospital discharge programme. So actually we may see a transfer of cost from the CCG into the hospital discharge programme, because the people in category 1 will still remain within category 1 and they won't be assessed. So what we're going to do with that is at the end of January, we're going to have a complete review of all of the budgets that are affected by that change to make sure that we are accurately predicting our position. It may bizarrely actually improve the position of the CCG.
Thanks, Linda.
Thank you very much. Peter, you have a question.
Yes, thank you, Dr. Wilson. Very short point on 10.1, decisions taken under executive's authority. The third bullet point down, under where it says the governing body had previously approved transferring the CCG's community grants to the ICPs. I think that should say transferring the administration of or management of, because what we haven't done is devolve the money to the ICPs.
I'm just wondering if Linda wants to come in, because that's something that we've discussed separately around whether the money is devolved or the responsibility, or both.
So in terms of this, we're very much aware of the pressure in the system around, you know, dealing with the COVID-19. So originally the idea was to move the management and the budgets into the ICP. But at the moment, that's not possible. So what we are going to do is we're going to work with the ICP, and the CCG will will support the ICP in terms of the administration and the payments while we go through. Hopefully this period of time will stop, and then we will be able to transfer it to them and they will do the commissioning of it as well. But at the moment, because of the pressures in the system, we are basically working with the ICP to roll forward the current existing grants, and then we will look to doing something hopefully from September onwards differently this year. Does that?
If I may, not quite. I think the point was around whether we have the powers to transfer funds to another organisation to disperse on our behalf, and I think that was the decision was the decision, if I recall, was to transfer the management of the budget, if you like, rather than the money itself.
Yeah, so I think the original idea was potentially to run into a subcontract arrangement with the lead contractor, which was the Countess of Chester, and we would have subcontracted to them the ability to commission from the third sector. But we're not doing that. But effectively what we're doing is we're working with the ICP. So we will maintain the money in the CCG, but we will work with the ICP and they will administer it. And at some point when we get a contracting system back, which we've obviously suspended at the moment, we'll move that forward in the way in which it was intended. Yeah, so we're keeping the money at the moment. Yes, you're right.
Thank you very much. Peter has a very content face, so I'm taking he was content with that answer. Thank you. Leslie, you've got a question.
Okay, I'm Leslie Appleton, governing body GP. Just a really quick question about obviously the important work that's going on with the maternity services, and I just wondered, obviously it'd be nice to sort of find out what the learning is from this, and wondered whether this would perhaps be coming through the quality meeting to see if there are any actions that come out of it. I know it's obviously there's delays and things given the current circumstances, but I think this is really important work going forwards. So,
Paula, are you going to comment on that?
Yeah, thank you. Paula Webb, Director of Quality, Patient Experience and Safeguarding. Just to say that all of our 3 trusts who've received the report have complied with the request to return the assurance template and the commitment to discuss at governing body resulting actions from the assurance template. And also as well, we'll then receive, I've received the summary along with my commissioning colleagues and clinical lead. from each of the trusts, but the actual in-depth detailed pieces of work now around their action plans are going through trust governance processes and through to their governing body meetings for discussion, which was the ask in the letter. I've absolute assurance that that process is going along exactly as it should do, and I've had sight of some of that information. So you're absolutely right, Leslie. What we will then do is, when the deadlines, which have been extended slightly in light of COVID, to make sure that it got the exact time and attention it needed through board of directors processes within trusts, we'll be able to bring a summary of that. And you'll see in the AA report is actually the list of the summative findings of the main issues that were identified through this first part of the review. This is a very extensive review. There is much more to come on this. Is only part one of the report. And then you'll see the recommendations listed there with then a subset of actions. So you're right, there's a lot to do, and my plan would then be to bring a summary of the action plans and the assurance from the trust through the Policy and Safeguarding Committee.
Thank you very much. At the moment, nobody else has got a hand up to ask any further questions, so I will ask. Oh, Suzanne, my apologies. You did put it in the chat. Suzanne.
Sorry, yeah, thanks, Andy. I've just put it in. Just on the commissioning, there was a note about the exec decision on a refresh, probably one for Tracy, a refresh of the 2021 commissioning intentions. I'm just wondering, quite sure what the decision was, whether it was just to do a refresh, or is this something that's coming to a governing body next month for us to look at, just to clarify? Thanks.
Hi, Suzanne. Yeah, happy to cover that. If I need to check the wording of the decision, we just discussed whether or not the commissioning and contracting intentions, the process for doing that. So yes, to answer your question, we do need to bring that through our usual governance structure, but it was just about acknowledging, given the planning guidance has been delayed, the policy issues that are being, policy discussions at a national level and COVID and other issues, that it would feel right to do a refresh of the previous year's commissioning intentions rather than a whole scale start again. So it's really just acknowledging that it would be refreshing what we already have rather than starting again and doing a huge piece of work. So that's what it was, Suzanne.
Okay, thanks. There was just a conversation we had at Chair's meeting, and one of the things was about, if we're just doing a refresh, and I understand the reasons why we are, given the circumstances and the absence of planning at the moment, how are we going to make sure that we use and capture the innovation and all the learnings from COVID, where we've increased our efficiencies, changed the way we work, etc. Just slightly concerned that a refresh won't necessarily capture those things. So probably looking for some assurance that that isn't the case, and that we will make sure those new ways of working and etc. are still captured in this refresh.
I think that's a really good point, and I think we absolutely must capture the learning and the new ways of working. I suppose the commissioning intentions were in line with the long-term plan. The objectives that within those are still right, I think, in the main, but it's the how we deliver that. I think that we, as you say, there is learning that needs to be incorporated within that. So I think I just want to give the assurance that yes, that learning has to be incorporated. I think it also needs to fit back with our revised strategic objectives that have been agreed, so that was part of it as well, and the ambitious intent that we have set for the development of our ICPs. So I think there are a few things to bring into there, but last year we spent an awful lot of time and energy setting those commissioning intentions, and I think it was just a nod to making sure that we don't necessarily need to start again. It's about resetting those. So I suppose I'm repeating myself, but also giving you the assurance, Suzanne.
Thanks, Tracy.
You're welcome.
Thank you very much. Any final questions on the AO's report? If not, thank you. We'll move on. We're asked to note the contents of that report, which I think we have done so. So that moves us on to the next item, which is item number 4.1, which is on page 28 of your pack, and it's the finance update. To you, please, Linda.
Thank you, Andy. Just a quick update on the financial position for the CCG. So the report outlines the current financial position as at the end of November 2020. We're this year almost considering the financial position in 2 6-month periods. So in the first 6 months, the CCG was fully funded for all its expenditure incurred and effectively had a balanced position at the end of September 2020. For the second 6 months to the 30th, a deficit is after the.
Linda, we're having quite a bit of problem with your audio.
All right.
Yeah.
Can you hear me now?
We can, but it might be that you might need to switch your video off if you're having connect.
Right. Hang on. Just has it stabilized?
We can hear you perfectly now. Yes. Yeah.
Okay. I'm really sorry. That was. I've had problems all week, really, on and off. So where did we get up to? Shall I start again? Yes. Okay. So this report's for the end of November period. So we're considering 2 6-month periods this year. Basically, the first 6 months to the end of September, we had a balanced position because we were fully funded for all of our expenditure by NHS England. So we got additional allocations to cover that, the costs. So in the second 6 months of the year, which is to the end of March 2021, we are predicting a 6.5 million deficit, but this is after the receipt of the monies to support the hospital discharge programme. Now, I know you're all aware of that because we've just talked about it before, but it is the monies which support the services for patients who are discharged from hospital, and those are also being funded nationally. In the performance at a glance summary, which is page 30, you'll see that though the financial position is expressed including the additional allocation and excluding the additional allocation, so you can see where we're up to. We continue to report that the most significant risks to the CCG are those related to the impact of COVID on the recurrent cost base, and what that means, both in terms of additional expenditure and also potentially in terms of the things Suzanne's talked about, where we've made efficiencies because of the way in which we're now delivering services. In terms of the running cost allocation, we are meeting the running cost allocation, and we are planning to meet the mental health investment standard, with the monies for that either having been spent or being planned to be spent by the end of March 2021. As we previously noted, it has been announced that the planning round for 21-22 has been deferred. And the current financial framework will be operating for the first quarter of 21-22. We're going to still, hopefully this afternoon, I'm going to receive some more information about how that will work locally, in terms of the payment levels to trusts, etc., and the timeframes. So we'll hopefully have more information for you the next time we meet on that. Whilst we haven't had a finance committee this month, we have supplied all of the detailed finance papers to the finance committee members. So hopefully they are available to them, but also to any members of the governing body who would like to receive them. Thank you. That was all I wanted to say, Andy, so back to you.
Thank you very much. We have Suzanne wants to come in, I believe. So Suzanne.
Thanks, Chair. Just a quick one, Linda. On the performance schedule, we've got the NHS volume, which is still only at 88%. I know we haven't had a finance committee meeting this month, but previously we discussed how we were going to get that back on track. I think we were quite keen to get a clean slate and hitting the target by the end of the financial year of March. I just think, can we have some assurance that I think it's Niall particularly is working on trying to clear this. I appreciate their pre-merger backlog. He's inherited invoices. They're mainly NHS, so the risk is minimal. But I just think going forward for the accounts, it would be nice to have this cleaned up, shall we say? So, yeah, are we working to plan on that?
Yeah, so we're working to have a report to the next finance committee, which will go through all of the age debtors and age creditors, so we can see exactly where we are, and hopefully we will understand then fully the impact of the things that were brought forward, because as you'll remember, we did have some issues with the merger in terms of items which were all put into one code, and they've all had to be manually dealt with, which has taken one person about 4 months to deal with. So we are still working on that, but there will be a report to the Finance Committee next month, which will go through the age debtors and the age creditors, and hopefully we will start to see that improving.
Thanks, Linda.
Thank you very much. At the moment, I don't have anybody else with questions, so I'll jump in with a general question, please, Linda. Clearly, we are still reporting not insignificant deficit position for the end of the year. And I understand we are living in the strangest of times, and we have very little control over the normal financial levers, or even normal contracting levers that we have and would normally use. But is there anything that we as a governing body should be considering or should be actioning in order to correct the position of that deficit, or is it simply that in the world we're living in there are no options, there is no space for us to move in?
Well, I suppose in terms of the way in which people are operating, I think they are being as robust as they can be with cost control. So obviously all of the additional costs that we incur all go through our usual probity routes in terms of SFIs, in terms of signing off expenditure. And we did do a budgeting exercise for the last 6 months of the year. So we are absolutely still keeping our cost control within the system. But we do have to recognise that we are in unusual times, and therefore services need to be supported, and are, I think, being supported where they needed to be supported. So in terms of doing quips and cost improvements, etc., no, I don't think that that is appropriate at this time, but I do think we still need to make sure that every penny that we are allocated is spent effectively for the patients of Cheshire, and I hope that we have systems in place which do that. I think we do. Does that answer your question?
Did you use the word hope there, Linda?
I said hope. I think we do. We do. We have, as you'll see, all the decisions are noted. We have decision logs. We have, and you have all been involved in some of the extraordinary meetings where we discuss all the expenditure, and we need to understand the quality and the service and all of it, as well as the money. So I think I'm absolutely sure that we have the probity and the resilient systems in place to ensure that we are spending our money as effectively as we can.
Thank you. That makes me happier. Lovely. Are there any further questions for Linda on the financial report? No. Thank you very much. I found it a very helpful summary, and it's a very short format, but actually for us non-finance folks, it's a very, very helpful and succinct summary. So thank you very much. Very useful. Okay. Right. That moves us. I'm sorry. We are asked to note the financial position reported on the 30th of November 2020. Note the financial risks currently facing the CCG, and the key issues being reported to the governing body in January 2021, which I believe that we have done. So I will look, there are no nodding heads, so we'll take that as noted. Thank you very much, Linda. And that moves us forward to item 5.1, which is our forward planner, which is on page 33 of your pack, and that is for noting. So if you ever have a look at that, and are there any comments or suggestions on that forward planner? No. Okay. That then, I believe, takes us to the end of this section of the meeting. Now, there is we have a second section, of course, which is where we're opening ourselves slightly to public scrutiny and questioning upon the COVID-19 vaccination. Now that is scheduled for 11:30. It's tempting to say, as we finish this early, that we could move that forward. I'm not sure that that's appropriate, because I think we are expecting members of the public that might join us just for that section. So I think we will close this part of the meeting, and we'll restart the next part of the meeting as it was planned, as the interactive session, and we'll open that at 11:30. So thank you very much for this section. Matthew, is that appropriate?
That's fine. Andy, I think it's just worth noting, obviously due to our technical problems at the beginning, what questions we've already received from members of the public are quite specific to the COVID section. So whilst we're not answering those questions in this part, we'll answer those questions in the next part of the governing body, if that's okay. Just also to reiterate, really, you know, we're welcoming questions from members of the public, which you can do on your screens, and you can submit them in the right hand side of your screen. So please, you know, if anyone's listening out there, please do send in your questions, as well as the ones that you've already thankfully sent in advance. But yes, I think it probably makes sense if we break and come back at 11:30, because that's really what has been advertised for people.
Thank you, Matt. So we apologies to a member of the public that may have joined us for not entertaining you for the full time that we promised, but we will try to do so appropriately from 11:30. So thank you very much. We'll close this part of the meeting and we'll rejoin by the same mechanism at 11:30. I will join earlier to make sure that it all works. So thank you very much. Yeah.
Wendy's bathed in sunlight.
Yes, it's most annoying actually. The sun will move around again, but it's a damn nuisance. The flooding around here is tremendous, absolutely huge. The river has burst its banks. It's all over the floodplain. We are a floodplain, so it is pretty grim.
Whereabouts are you, Wendy?
Farndon, so just south of Cheshire. Yeah.
I know Didsbury's.
Can I just remind everybody that we're live?
Okay.
Right, it is 11:30, so we'll recommence if that's suitable. So please continue social distancing, please continue to wear a mask, please continue to ventilate indoor spaces. These are extraordinarily important and we know they're effective against the virus. So it's great that we have a vaccination program. Let's go on to discuss that. But we also need to remember that we are still in the middle of a very, very serious pandemic, which is putting the health service under tremendous pressure. And as we just heard, behind every one of those statistics is our sad stories of lost loved ones, and we all need to bear that in mind. So having said that, I'm going to move on to ask Tracy to talk to us a little bit about the vaccination programme locally and what has been happening. So Tracy, can I hand over to you, please?
Thank you, Chair. So I'm Tracy Cole, Director of Strategy and Partnerships within the CCG and leading across Cheshire, along with many people in terms of that community effort and partnership approach on the rollout of the vaccination programme across Cheshire. So just a few things that I'd like to say, and then we are, as you say, opening up to questions so that we can use this as an opportunity to really raise awareness and make sure that everybody knows what we're doing and what's needed, and so that we continue to provide those key messages. I suppose I just want to start from the top really and use some of the words that are being used nationally, which is that vaccination is the best way out of this pandemic. And we have 3 vaccines authorised in the UK, which is more than any other country in the world. This is the largest vaccination programme in British history. And it's an epic feat of heroic will to get to where we are now and continue to run other services. And it is a team effort and there is a partnership approach. And so I really want to make sure that we thank that community effort and thank everybody that's been involved. And that would be staff, volunteers, the patients who've come and had their vaccinations and our public for supporting the work that we're doing. So I think there's some real thank yous required across the board. And don't forget that people are continuing to run existing services whilst this is going on. So in Cheshire, we're very proud that at the moment we have 23 sites. So 18 of those are run by primary care networks, which is groups of GPs who have formed together to work out how they will locally provide vaccination sites. We have 18 of those. We have 4 hospital hubs. 2 of those are in Chester, 1 is in Crewe and the other one in Macclesfield, and we currently have a pharmacy in Macclesfield. When we cover this again in future weeks, those numbers will change, and it is likely that they will increase as we are also evaluating other options, including whether we need further larger sites in addition to, or how we make sure that we cover the population and make sure that we have those locally available sites. We are on track to deliver some very, very tight deadlines and targets, not without challenge, as we're also dealing with a range of other things such as staff themselves having COVID or other sickness. We've also will not have escaped everybody that we're dealing with floods in Cheshire at the moment, which is also affecting how we do that. But we're on track to stick to what we've been asked to do nationally, which is around making sure that all care home residents and carers in those care homes receive the vaccination by the 25th of February, that's this January, this Sunday, and that frontline health and care staff are offered the dose by the end of January, and by the middle of February that those priority cohort groups that have been set nationally, groups 1 to 4, are offered their jab by the 15th of February. Thereafter, we're working to the 19th of April for the other priority groups. So that is a tremendous thing to be able to report on. And I suppose just the closing remarks from me, and then I'm sure we'll open up to questions, is that it is safe, it is effective, and it is free. And what we're asking is that we have been inundated with requests for when will individual people receive their vaccination. And I guess we would ask that you wait for us to contact you, so that we can make sure that we put all our energy into running the services and providing the vaccinations as well, and that we will get in touch with you, and we will also then ensure that if anybody has concerns, that they can have that contact. But we're asking everybody to understand that we're working through the groups as we've been asked to do. And we then follow up with, I think, the message that Dr. Wilson gave, and linking back to the sobering message from the lady in the video, which is keep following the rules so that we continue to control the spread of the virus until the vaccine is rolled out across Cheshire for all our residents. So thank you for letting me cover that off. I'm sure there's lots more that we will want to get into in the question session, and we're joined by a couple of colleagues to help us do that.
Thank you very much. I just remind anybody that may be watching, if you have questions, if you type them into the box for us, and Katie, who's our voice in the sky, will be watching over those and collate them for us and ask the question for us. But we're going to start off with some questions directly from the governing body. And in fact, I'm going to start off by reading out a question that Ian Ashworth, Director of Public Health for Cheshire West, has put in, who can't be with us today, and then I'll move on to other colleagues if you want to come in with your questions. So the question from Ian is: mass vaccination sites are in place now at the Etihad campus in Manchester and St Helens Rugby Club. Is there likely to be a more local mass vaccination centre for Cheshire residents to access, and what's the advice for people who receive an invitation to one of these sites?
Would you like me to answer that question?
Yeah, if just jump in, if from anyone on the panel, if you want to just jump in.
So 2 parts to that question. One is, will there be a mass vaccination site or sites in Cheshire, and what do you do if you receive a letter from one of the sites that are in existence at the moment? So the first part of that question is, we are looking at all the options. What is the best way to provide this vaccination across Cheshire that fits with our population? So we haven't ruled out whether or not we should have a or more than one mass vaccination site in Cheshire. And so we are looking at those options now, and it's very much about what does our population need. So we haven't said no to it, and there are discussions going on later on today and further on this week with partners as to how we best look at those options. What we want to do though for us is get the vaccine deployed and out and provided as fast as possible. And so if we need those sites, we will be putting forward to do that. But it is a massive requirement to staff them, and also we need to have the supply of vaccination and also make sure that they are in the right place and able to be operational in a clinical safe way. So there are a number of things to consider. But I would say at the moment, whilst we don't have a mass vaccination site, we do have 23 sites across Cheshire. That's phenomenal in the time that it took to get those set up, and also means that in most local areas, people are not far from a place to receive their vaccination. We are also looking at other pharmacies coming online. That's not commissioned by the CCG, so it's something that Cheshire, Merseyside and the national team are commissioning. So it is likely that in addition to those 23 sites that I've mentioned, that we'll be reporting other pharmacies that are coming online to provide the vaccinations in addition to those 23 sites. The second part of the question was, what do people do if they receive a letter? Again, the vaccination, the mass vaccination sites, so for us that's Manchester and also Birmingham for some people, and St Helens is another site. They may receive a letter saying, would you like to come in for your vaccination? If you receive that letter, people are able to go, or they can wait to be contacted by their local primary care network, or it's their choice, and that's the advice that we're giving them. So if it's not convenient, you are able to wait to be invited to be vaccinated in a more local situation. So it's a choice option.
Lovely. Thank you very much, Tracy. I'm going to move now to Suzanne. You have one, possibly two questions for us, Suzanne?
Yeah, thanks for putting me on the spot, Andy. One of my questions was about some of the negative press we've seen at the moment about people not coming forward, perhaps those in the BAME community particularly, who may have concerns. And one of the things I was going to ask is, how are we addressing that, and how are we targeting our population who may have some concerns about coming forward for their vaccine, whether there's any truth in those rumours that are putting them off?
Thank you. Who's going to take that? Tracy, you look like you.
I was going to suggest that Dr. McAlvey might want to talk through the safety aspects.
Yeah, I wonder whether Dr. McAlvey agrees. He does.
Absolutely fine. Thanks, Andy. Andy McAlvey. I'm one of the joint medical directors of the CCG, and providing some clinical support as well to the COVID vaccination programme across Cheshire. Thanks, Suzanne. Really important topic that we need to discuss, and it is actually looking at looking wider and health and care, and we're working with the local authority to look at certain populations that we actually need to target, and we're using that within our communications team as well to actually focus really on areas, not just actually looking at those areas that we might think might not take this up, but actually be more proactive. And so we have got plans in working towards those local communities and making sure that when we plan different services around Cheshire, they're actually meeting the needs of the population, not just where we can physically put something and hope that that's going to suffice. You're absolutely right. We need to actually probably encourage our residents who've had the vaccinations as well, to encourage, the video that we saw there. Lots of patients have actually received the vaccine, and actually, feedback from the sites is that it's been terrific to actually see some of the patients who haven't been out for about 9-10 months feeling more confident to have the vaccine and use those communications that will actually spread that good word.
Thank you very much. Suzanne, has that answered your question?
Yeah, I mean, I was looking for a slightly more detailed answer on the comms where we're specifically targeting whether it's going through the religious route or whether it's, it is broader than BAME, the travelling community, where some of my colleagues have flagged as well about addressing those. So I'm wondering whether we've got a more specific action plan in place. I understand that we're trying to locate the vaccination sites, obviously, to meet the local demand and the area, rather than just, you don't want 2 or 3 in one site. But I think it's about, it's not so much that as about targeting those individuals that may be reluctant to come forward to have the vaccination for whatever reason. But there's some that we are being flagged more so in the paper that have some reservations.
Would you like me to chip in to add to the answer? We do have a really comprehensive plan, so certainly being led by Jonathan Taylor as part of Matthew Cunningham's team, and linking in with Warrington and Holton. We're looking at a whole plan around this. And as you say, it's not just communicating, it's engaging, isn't it, Suzanne? So there are a range of detailed options being reviewed around how we link in with mosques, barbershops, employers, you name it, and how we use community leaders to support that, because there will be different fears from different parts of our community, and some of those come back to cultural and religious beliefs, as well as transport and other aspects that we need to link in with. So at the moment we are finding a very high uptake of the vaccination, and that may be partly due to the demographic that we're working with, that the do not attend rate is absolutely minimal, lower than anything we've ever seen before. So people who are being asked to have the vaccination are willingly going, as you saw in the video. But as we move to potentially a younger group or a more diverse group, we will need to change the way that we engage, and that needs to be about us linking in, and so we will be wanting to commit some champions as well. So I'm sure that Jonathan Taylor will be keen to start to engage and see that other champions who are willing to say, I've had the vaccination and I believe in it, and help us get that message out. So really interesting plans that I think we'll bring back in due course, and also how we commission services that are hard to reach. Cheshire's got a large boating community, a travelling community. What are we doing about those that are homeless? There's a range of different factors, and it'd be really key to work with our primary care networks who understand their population very well, so they can help us to tell us what we need to do. The final thing is that we've had some input from the drug and alcohol services, who've also said that they would help us to do that. So there are a variety of strands to that plan, Suzanne, that I think we can provide more detail on in due course, if that helps.
Thanks, Tracy. Are we going to monitor those and track, so we'll be able to identify where the do not attends are happening over time, and we can target those more again specifically if it's not as successful the first time round?
Yes, absolutely. And at the moment, we're dealing with large groups, and we're trying to make sure that we get as many people in as possible. But there will come a point where we notice where we've got areas and groups and individuals who've not attended, and then there will be other attempts to try and engage and encourage and make possible. The other thing is, we've also had an offer from Cheshire Fire and Rescue, where if we aren't able to get in contact with someone, they will conduct a safe and well visit, make sure that person's all right, and do everything they can to check up on them and help them with transport if required. And also we're putting in a housebound service so that we can get out to those who are unable to travel. So there are an awful lot of different things being done to make sure that we reach every part of our population.
That's great. Thanks, Tracy.
Thank you very much. I know from updates on my practice WhatsApp group that we're out vaccinating people in homes today, so I'm sure other practices are doing similar things. Can I move please to Peter? I think you might have a question.
Thank you very much, Dr. Wilson. My name is Peter Munday. I'm one of the lay members for governance on Cheshire CCG. My question has probably just been answered by Tracy regarding what if somebody can't get to a vaccination centre, and I'm thinking particularly, as we do, of some neighbours of ours who are shielding and who I think will be very unlikely to respond to a call to come to a centre to be vaccinated. And it would be an intrusion, as from our point of view, to be chivying them along. And I just wondered, what I think you've already spoken, Tracy, about the alternatives to coming to a vaccination centre, but I wonder if you could explain a little bit more about what those alternatives might be.
Thank you, Peter. Just before I do, we're really grateful to have Rod Thompson with us. I'm wondering if he wanted to give any information on how we're supporting those who are shielding and how that then links in very carefully with this programme.
Thanks, Tracy. One of the things that both of the local authorities have been doing is tapping into the volunteers network that we established at the beginning of the COVID pandemic, and that's included individuals who are happy to provide some transport support. In Cheshire East's case, it's our People Helping People programme. So working with the primary care networks, we're happy to try and link our volunteers who have had some screening to make sure that they're appropriate for the task, to help such families to be able to go for vaccination.
Thank you, Rod. I think that then complements the things that I've said already, Peter. We are right at the beginning of this programme, and so at the moment we were waiting for the standard operating procedure to be agreed, where we could start to go into care homes and into housebound homes as well. So it's only just beginning, but we will be working with our primary care networks and our community services to adapt to whatever the needs are, and working with schools and a range of other community organisations as to how we can best provide the vaccination in the right way. But we do have to think about the most efficient model as well. So we will be best able to quickly vaccinate if we can do this in bigger sites, but it has to be adaptable to meet the needs of the population.
Peter, thanks for the question as well. You know, I think what we've been trying to do as well in primary care, and actually those principles in the primary care networks, we've already managed to vaccinate lots of patients, clinical extremely vulnerable patients, with the flu vaccine. So we've got models in place, and it's at the heart of primary care and general practice to provide those safe environments. So it's definitely high on our priority list. The models are rapidly changing too. So it's actually having the facility to use different vaccines in different ways, as Tracy's alluded to. So roving vaccination type models are actually going live this week, next week, in how we can safely provide that vaccine, both in care homes, both at housebound. We're actually encouraging, and it's important for the patients who are clinically extremely vulnerable to have confidence. We saw that certainly in our flu programs that were practice-based, but all of those vaccine programs that I've heard in primary care in Cheshire will run extremely well. It's confidence that primary care has run these kind of programs for many years with the flu program on an annual basis. So the slick systems there, and I think what the patients saw was confidence in those systems. So it's with those principles that we're going to still deliver a safe vaccine to that population.
Thank you very much.
Thank you both to you for that. I'm going to move on to Dan. Dan's submitted a question, but it may have been partly answered as we've been discussing. But Dan, do you want to voice it for us anyway? And
Yeah, thanks, Andy. So Dan Howcroft, on the secondary care doctor member of the governing body. So it has been covered really. It was specifically around the DNA rates that we're seeing, or people who are declining vaccines that have been offered. I think Tracy mentioned that the DNA rate is next to nothing, and I think also between Tracy and Andy answered the issue around how we might have to address different cohorts, and perhaps the current cohort is not necessarily representative of the whole population. The only thing I was going to say is I thought it was a great video as well. So well done for putting that together. It was really useful and I think really powerful. So thank you.
Thank you for that. Sorry?
No, sorry, apologies.
A comment?
I was just wondering if our GP governing body members wanted to comment on the take-up rate. So Leslie, Sinead, Mike might want to just comment on if they've had any different experiences.
I'm happy if that's okay, Andy.
I'll go Sinead, then I'll come to you, Mike.
Okay.
Okay. Feel guilty now. Sorry, Mike. No, I was just going to say we've had very similar experience in the Nantwich primary care network that I actually work clinically, and just very, very high uptake rates. Yeah.
Mike?
Yeah. That's it, really.
Thanks, Andy. So again, Mike Clark, governing body GP. So again, just to reflect on that as well, not only have I been vaccinating, I've been helping our admin staff ringing patients as well. Very few DNAs. Patients very, very appreciative of the phone calls and the offer for vaccines. And yeah, just people are just so impressed with the system generally that they're just very happy to come in. Even the clinically extremely vulnerable patients, they do feel safe coming into primary care, particularly, rather than travelling any distance to other centres. And even though they're shielded, extremely clinically vulnerable patients, they're coming down, they're taking up the offer, they're not staying away. They see it as essential treatment, which is in guidance for their movements.
Lovely, thank you. And Mike, I think we can probably stay with you because actually I think you're probably the next person to ask a question.
Yeah. So my question was more in relation to the system in general, but particularly again to NHS England and improvements as to what is the system doing to ensure that smooth supply of vaccine to sites, particularly in how they're trying to avoid the potential risk of last-minute changes to delivery of the vaccine to those sites, particularly because that impacts on patients as well as us as delivery sites, being able to manage that whole process. So yeah, if anybody's got any answers to how we're managing to do that and to improve the system.
Any offers on that? Tracy?
I'll have a go. I think if Claire was here, Claire obviously sends her apologies. She would have told you what she's doing to escalate this issue at the gold command level, which is at northwest level and then feeds internationally. We are very much working within the parameters of the delivery system that's been put in place, and so it's entirely out of our hands, as you know. But at the moment we've got this push delivery system. For those that know about supply chain, it's about, you know, having it pushed to you rather than being order and being able to order, and we accept that that is not without issue. And so I think that there's a lot being done to smooth that, and there are plans for that to be come into a pull model, which would be much more traditional, with ordering what you want when you want it and receiving it when you want it. I don't think it's been without difficulty about the speed within which a campaign has been set up across our nation, and so I think things are improving, and we're working really closely with NHS England on that, and hopefully we'll see things become smoother as we go.
Lovely, thank you very much, Tracy. Mike looks content with that. Brilliant. So if you can move on to a next. Well, let's not. I think I've had a message so that we are getting plenty of messages questions in from the public. So with governing body members' permission, I'm going to ask one more question from us, and then I'm going to move on to questions from the public, because we are really sort of giving some time for the public to ask their questions. So can I go to Chris, please, Chris Lynch, with your question?
Yeah, thank you, Chris Lynch, Corbett lay member. No, to be honest, Tracy's covered what I was thinking, and my point was really that sort of what are we doing to engage rather than just get the message. So, you know, I'd rather we just carry on with the questions from the public, because I think that's how we're doing it. So yeah.
Lovely, brilliant. In which case I will turn to the mysterious voice in the sky, who's Katie, to tell us how we're doing with questions, and perhaps poses some questions from the public. Katie.
Thank you, Dr. Wilson. We've got plenty of questions. One of the first questions that we've had, and a couple of people have asked this, people from deprived areas are being asked to travel long distances to get their vaccine. If they rely on public transport or taxis, this is making attending the appointments on time and safely really tricky and expensive. Have we built this into any of our plans?
I'm looking for somebody to pick that up. Andy? Sorry,
happy to. Yeah, no, happy to. It's a crucial point, and when we're looking at the vaccination sites, and we're looking at mass vaccination sites, we're looking at primary care sites, and we're looking at our pharmacy sites, which are the current models that are emerging, it's absolutely clear when we look at our map of Cheshire where our need is. And it's not just about population, it's not just about the numbers. We understand there's rural issues too, and so we're looking at driving distances, but actually in deprivation. So it is crucial that the models that we're creating fit the needs of our population. And you're absolutely right. We don't want to be looking at our deprived areas in Cheshire and actually expecting them to drive any amount of distances. So focusing the services around the needs of the population is crucial. And that's actually what's happening in our planning meetings. So it is extremely high up on our priority list of how we tackle, and in numbers and at speed and safely, how we tackle this. And we know from our deprived areas as well that they can be more susceptible to this vile disease that COVID-19 is. So it's our highest priority.
Thank you very much, Andy. And Sinead, I think you can add to that.
Yeah, just to back up everything Andy said, and just to say this is one of the reasons why we went for so many primary care network sites across Cheshire. So to have 18 sites, not all parts of the country are going for so many sites, but we felt very, very strongly we're a rural population. Public transport is difficult. It's difficult for people to get around. Our most susceptible people to COVID are also the ones who are most likely to find it difficult to get to these big mass vaccination centres, for example. So I think that question just justifies the approach we've taken so far, but there's still lots more work to do, as Andy and Tracy have said, to make sure that as we go forward, everybody can access these vaccinations easily. Thanks, Andy.
Thank you. And I suppose that feeds into some previous questions, doesn't it, about how we're monitoring. So how will we know if people are having to decline invitations to attend because they aren't able to attend because they can't afford or don't have the ability to get the transport? I suppose that would be a further question. I think Gwydion, you were going to come in then. You indicated you might do, is that correct? No, Tracy was though. Tracy.
Yeah, just to add to that, we're working really closely with our two local authorities, and Rod is here obviously today. And if we need to consider whether our public transport can adapt to meet the needs as well, that's something that I think we can bring up. So I think the question is really helpful to remind us of that. So we can't solve that here, but certainly I know both the leads that we've got from Cheshire West and Chester Council and Rod from Cheshire East Council would be willing to work with us to see whether we need to look if there are other support mechanisms, and how that is also, the cost of that is taken into account as well. So I can't make any promises here, but what I think we can do is make sure that we are making further considerations about those needs for people and working with our partners to do so.
Thank you. I think it's certainly is a very helpful question, isn't it, to make sure. I know it was already being considered. In fact, we discussed it this morning in a closed meeting, but it is a very timely reminder that that's a very important issue. Katie, do we have further questions, please?
We do indeed. We're having quite a few questions around priority and the cohort allocation. I'll give a couple of examples. The first that we've had asked, are parent carers on the priority list? MenCap and Contact have shared information that parent carers who have carer allowances are now included in cohort 6. Is this correct? As some are being told by GPs that they're not within this cohort.
And is somebody able to take that? Tracy? I think you're muted, Tracy.
Oh, sorry about that. We're working through the priority list that has been provided nationally, and you'll know there's 9 groups within that priority list. So I think the question specifically relates around whether people are in or out priority group 6, which I've just pulled up to be clear on it. That's all individuals aged 16 to 64 years with underlying health conditions which put them at higher risk of serious disease and mortality. At the moment, we're being asked to focus on priority groups 1 to 4, and we are waiting further guidance on the other priority groups, and particularly that one, because it doesn't just relate to age. So I don't think we could answer the specific question at the moment as to whether that group that have been asked about are in that priority group. But we will then work within the guidance and make clear and have what the process is for being invited in as per that priority group. So I don't know if anybody else wants to add to my answer to give it any more breadth, but that's how we would work through that.
Can I jump in just to check, Katie? The question is specifically about carers, is it? It's people who
Yes,
care.
specifically about parent carers, that question.
Yeah. You have anything to add to Gwydion?
I wasn't aware, but I've just been Googling, and online it seems to suggest that carers in receipt of carers allowance are going to be in group 6. I think that's very new.
Okay, and we are the guidance is ever changing, and I think that would be a helpful addition. So we'll take that into account. Katie, further questions, please.
So this is around the delivery of the vaccine. Is it known if when the vaccine programme moves to using predominantly the AstraZeneca Oxford vaccine with refrigerated storage conditions, will it be possible to vaccinate from GP surgeries rather than the vaccination centres? This would make it more time and cost efficient for both the clinical staff and the patients.
There might be a number of people who want to answer that, but I thought Dr. McAlvey would be the first. Dr. McAlvey.
Delighted to answer that one. Undoubtedly, the AZ vaccine does give us greater flexibility. It's the Pfizer vaccine is a very, very fragile vaccine, and the AZ vaccine, another exceptionally good vaccine, but offers a little bit more that we can do with transport. We are working though with the national ways that we can work with this. So there's national SOPs that are sent out to our areas to actually say this is how you utilize the vaccine. Some of the current limitations at the moment with the AZ vaccine is if you do move it from a designated site to a primary care site, it needs to be used pretty quickly that following 24 hours. So it still provides some limitations. It's still a challenge for arranging the vaccinations, to arranging clinics. Some of the flexibility that I've seen recently is actually the housebound, is actually the care homes. It offers that greater flexibility, but I don't think we can just replicate like a flu vaccine clinic arrangements just at the moment. There are still some limitations in how we can deliver the program. So although I welcome the AZ vaccine, I welcome the question, it still provides some logistical difficulties.
Thank you. I imagine there will also be a question of the ability to continue to run normal GP services with using people's own practices. I think the vast majority of GP and GP staff would be much happier vaccinating within their own buildings where they're familiar, but it may make some constraints upon their ability to continue operating ordinary GP services for some buildings, won't it? So there'll be a number of considerations there as well, won't there? Katie, we've got a further question, please.
Again, this is linked to the delivery of the vaccine. The vaccination centre near me opened last week and started vaccinating, but now it's closed. Why have the clinics been stopped or cancelled?
We may find that difficult if we don't know the specifics, but does anybody want to jump in? It may be that the vaccine supply isn't continuous, so that a centre may have been open for often 3 days to deliver a box of Pfizer, and then may not be open for a couple of days following that. But Gwydion, did you want to comment on that?
I think that's likely, Andy. So the site in Alsager, for example, after Sunday, there are no plans for us to be vaccinating for the rest of that following week due to vaccine availability.
Thank you. Nobody else is. Sinead.
Just to back up what Gwydion said, in our Nantwich and rural area as an example, we've received a vaccine for 2 weeks in a row, the Pfizer vaccine, when we haven't received any this week because it's, as Tracy said, a push model. It means we just get what we get. As long as we say we're ready for vaccination, which all of the sites are now, we then just have to wait and see what we get. And we normally get up to a week's notice, sometimes not that long. And then we make sure we can give that vaccine very soon. If it's Pfizer, it needs to be given within 3.5 days after it's arrived. So as sites, we don't have a lot of control as to what days we do this on, and there will be weeks when some centres aren't active. All the public need to know is that we all chomping at the bit to give this vaccine. Every health and social care professional I know and volunteer I know will drop everything to come and give it when we've got it. You know, and we keep our general practices going as well, but we all stretch ourselves. We do extra hours. We, you know, we're using colleagues who've come back, who've retired, to help us keep everything going together, but we can only deliver what we've got. So you just have our assurance that anything that we can be provided with in primary care networks, we are then vaccinating with those vaccines straight away. And as Tracy said, the supply might get a little bit more predictable over time, so it'll be easy for us to then let the public know as well, you know, maybe more than a week in advance when we'll be vaccinating as well. Thanks.
Thank you very much. Katie, can we go to another question, please?
Yes, there's two questions that I think are linked. The first is, I have friends in Manchester and they've told me they're starting to vaccinate other cohorts. Why is Cheshire behind in vaccinating priority groups? And it's linked to, I would like to know, since you should now be vaccinating over 70s, have you started to do this yet?
So who's going to take those two linked questions? So I think we've got Andy and Rod is going to come in as well. So do you want to start, Andy?
Yes, sure, I'll start. Yes, we are very keen to spin down the cohorts as we see fit. I think there's certainly been some national anxiety that we actually do it in a staged fashion. You know, the reason for actually the vaccinations is to limit how ill people get, to limit the need for the, you know, the fact that they might need to be hospitalized because you can get so unwell with this. That is the purpose of the vaccination. So they're targeting in that way. And so it's been, you know, care homes and the carers. It's been the over 80s purely for that reason. It's been logistically difficult. You know, you can understand the planning that's gone involved with this, and what the sites have done, and the primary care sites and the hospital sites, is at exceptional speed provide a safe and effective service. They've needed a site assurance system as well, so that's been nationally dictated to actually make sure that all the sites that have put themselves forward as vaccination sites to have a whole appraisal really, and that's been led and supported by the CCG to actually make sure that the sites are delivering it in the safest possible fashion, both for utilising the vaccine and making sure the patient journey through those sites is a safe one. That's taken up some time, but it's been done rapidly by an expert team from the CCG. And it's great to see that because we've got a wide expanse of sites now, on a wide number of sites, as Dr. Clark has mentioned, we're actually able and are ahead of national targets to vaccinate the cohorts. So we're very keen that I think we're going to actually get all our nursing, our care home patients vaccinated within the national deadlines put forward. Certainly the cohorts 1 and 2 we're comfortable with. So we are, I'd say, certainly on target with some of the national programs, and because of the number of sites that we've got now, we're confident we'll be able to maintain that pace.
Thank you, Andy. For clarity, the deadline for care homes is Sunday, and we are, you said, and cohorts 1 and 2 are care homes and over 80s healthcare staff.
And just yeah.
I know that you'll be very familiar with the cohorts, but not everybody will be quite so familiar.
Apologies, you're quite right.
Rod, you wanted to come in, and after Rod has spoken, I'll just reflection. The question was specifically on why are we not vaccinating over 70s? So I'll come back and say, even if we don't can come back to that as a question.
Okay, and apologies for the interesting background. The web link wasn't great, so I'm now sitting on the floor in my hall answering the questions. So apologies for that. Key thing links to this massive national programme of getting, in effect, 60 million people vaccinated twice. And the initial Pfizer supply came out on a limited basis. Because of the requirements of keeping it in very cold storage, a limited number of national centres were identified. And in our case, initially, it was the Countess of Chester Hospital, which meant that there was a slight bias across to the west of the county, not because anybody within the CCG wanted to organise that in that way, or indeed the local authorities, but simply because to get the programme started, you had to start somewhere. And it meant in the 70 sites across the country, some areas were able to get off to a very quick start, others have had to catch up. So it's not that the Cheshire East area was better than the Cheshire West or vice versa. It was just that practical element of you have to get the programme started within the limitations. Where do you start? The critical thing for people locally, particularly in Cheshire East, because of our sites being slower to start, was that by a remarkable effort by the primary care networks, we have got so many sites up and running. Our two hospitals have been working magnificently to get up to speed, and consequently, as Andy was highlighting, we've now caught up to a significant extent. But the starting point for this, and the reason for the differences in areas like Manchester, was that they got their supplies first. They were able to set up their clinics first. What's been done in Cheshire East is a remarkable piece of work, along with Cheshire West, to get those sites up and running and as many people as possible vaccinated. Thanks.
Thank you very much, Rob. That's very, very, very helpful. Is anybody able to answer the specific question? When we'll be vaccinating over sepsis? Tracy?
Yeah, everything that's been said is entirely accurate, and thank you, Rod, for moving to your hall. That shows dedication, doesn't it? The factors are supply, start date, and numbers of population in each area, and numbers of people within those cohorts. So if you have areas where they have larger number of older people, it's going to take longer to get through that population. So not all things are equal, and so Manchester's the example that we've used, but there are other examples where it may appear that someone's going faster than somebody else. The date by which we're working to are the dates that I mentioned initially. So as you heard, by Sunday, we're trying to get through all of the care homes, and we're on track to do that. We're then working to make sure that all frontline health and care staff are done by the end of January, and all priority groups, cohorts 1 to 4, which does include the over 70s, to be vaccinated by the 15th of February. So if a person that's asked the question hasn't been invited now, it doesn't mean you won't be, and it's just a case of going back to that, you will be called within that time scale, but it may be that you're in an area where there are more older people, and so it's taking us longer to get through there. But we are now in some of the areas where they have less population or less older people, or they started first, they may be slightly further ahead, but we will all get there in the end and meet those targets. Does that help?
I think it does. Thank you, Tracy. Can we have another question, please, Katie?
Of course. The question asks, is there a dashboard or plans for a dashboard showing the percentage invited, vaccinated and opt-out for each cohort, so we can see how far through the cohorts we are?
I'm sure someone's going to answer this one. Tracy?
I'm trying not to bore you all by answering all the questions, but yes, absolutely. We can't do this without a dashboard. We're just waiting for the national team to help us with that and be clear that we're able to publicise that information. When we have that, we will, and we are working with each of our sites to help them to understand, and we will do that to make sure they're on track to do that. So yes, it's coming, I think, is the short answer.
Thank you very much. And colleagues, members of the public might notice that some colleagues are having to leave us because there is a gold command call, I believe. So some people are having to leave for that, which is entirely understandable. Katie, can we have another question, please?
Yes, there's two questions that are linked. So the first, it's a statement. So COVID has made me very nervous about going out in case I catch it. When it's my turn for a vaccine, can I apply to have the vaccine at home? And another statement or question, I think it's probably linked to the parent carer question. If a child is unwell, a parent may not be able to make the appointment through no fault of their own. So are home visits an option for the vaccination?
Okay. Dr. McKelvey.
I think that the flexibility of requests, I think we've got to look at the capacity of the organising sites to actually look at that. I understand, and I certainly throughout the flu programme met lots of my patients, you know, who had been clinically extremely vulnerable, had been shielded since March, but were extremely relieved to understand that the sites are safe. They are all trying to operate to all the guidance of keeping those sites safe, being, you know, COVID secure. So I'd like to offer this to the public to actually say, in setting up these sites, we need to make sure that they're safe sites to deliver these vaccines. And, you know, those sites have got to be safe for the current cohort, which is our most vulnerable cohort. So I want those patients to have the confidence that they can come forward to those sites. Many are, you've seen the video today, and they're confident, they're content, and they're very happy with the slick procedures in place at each of the sites, so have that confidence. So I don't think there'd be a flexibility to have it on request or on demand for home visits. I'd also like to reiterate that if patients are too unwell to actually receive their vaccines on the day, please get in touch. You know, if you're going to be at a practice-based setting, there will be sweep-ups as well. So we need to, you know, there will be other opportunities to get your vaccine. So, you know, I wouldn't, as a clinician, want you to actually receive any vaccine if you're not well enough to take it. That wouldn't be a sensible idea, and one that I'd support, but there certainly will be other opportunities. So I don't think there's the flexibility to have home visits on request, but be confident that the services set up are safe to actually safe, and the way we've organised them are safe to deliver it.
Thank you, Andy. Very helpful. Katie, another question, please.
Apologies. So the questions around the types of vaccine. So which vaccine are you using at present? When will you use the AZ vaccine? And can I choose which vaccine or which type of vaccine I have?
Okay, some good questions. Dr. McKelvey.
So there's two vaccines that we're utilising at the moment. The first vaccine, the very fragile one, if we remember, is the Pfizer vaccine. So that's the one that's being delivered at many of the sites at the moment. The deliveries that are going to the hospitals, they're mixed too, but I think because the hospital sites have got the big freezer units, they're the ones that are being able to manage the Pfizer vaccine in a slightly easier way, because there's not the transport difficulties or the timing difficulties that you find within the primary care networks. So the AZ vaccine, which has been the second one that was authorised for use in the UK, we're keener within the community to actually be utilising that one. And when we talk about some of the potential plans for other sites in Cheshire, so the mass vaccination sites, you know, the planning around them again will be around the AZ vaccine. It's easier to store, easier to deliver. So they're the two vaccines. There is another vaccine, the Moderna vaccine, similar again to the Pfizer vaccine within its freezing requirements. We anticipate access to that later in, you know, into the spring. So we'll be incorporating that. The country's bought, I think it was initially 5, now it might have been up to about 15 million doses of the Moderna vaccine. But it's a complicated process. and the complication is the delivery of what's available and how we utilize that. There won't be a menu. What we'll be doing is looking at certain cohorts to see who's most appropriate for some vaccines. There can be certain issues, but no, there won't be a particular menu. But if there are any kind of like previous reactions to the vaccines, of course, you wouldn't be able to have the second doses, but we'd be looking at that on a clinical aspect. But no, we're just thankful that we've got the vaccine within the UK and within Cheshire, and actually delivering those services. Both vaccines that we're utilising at the moment have got very good numbers. I'm very happy with some of the safety data that I'm seeing coming out. So I think we should embrace the fact that we've got those vaccines and utilise them as appropriately as we can. Thank you.
Thank you, Andy. Katie, got a further question?
Yes, one more question. So there's a question around, have you had any examples of vaccines being left over at the end of sessions, and what have you done with this?
So yes, Leslie, and then we'll go to Gwydion.
When we've done I'm Leslie Appleton, one of the governing body GPs and a GP in Neston. So when we've done the sort of Pfizer vaccine days, so obviously that's a more unstable vaccine, so people have had to come to the centre. We've had no doses left over. We've used every single one. And even when we've used the AstraZeneca, when we've been out to care homes, we had 4 doses left, and our practice nurse managed to use those on some of our housebound patients. So we're trying very hard to use every single drop that's left in the vials. So as far as we're concerned, we're doing our very best not to waste any at all.
Gwydion, did you want to add to that?
Gwydion Rees GP and Allstage are exactly the same experience in our sites as with Leslie. Thank you.
Thank you very much. Did I get the feeling we were coming to the end of public questions, Katie, or are there more?
Well, we've got 2 more questions. Yes. So the first asks, what booking system are you using to manage the cohort invitations? Is it centrally or up to each practice? As we move on to the more internet savvy generations, will you be inviting via SMS and email rather than Royal Mail, which is very delayed at the moment?
Right, I can say that I know that we are already inviting by SMS messages. I know that we had 300 people in the OV80s cohort book within 30 minutes of sending out an SMS message. But anyway, I will pass over to the panel. Who would like to take that question in its fullest form?
More than happy to start, Andy, if you want me to start and for people to fill in. So great question. What we've actually asked, certainly, so there's different booking systems certainly within the hospital sites. They've been, they've had to adapt in the cohort they've been able to invite. It's clearer for the primary care sites that you've got those, we call them the JCVI, so the Community on Vaccinations and Immunisations that we've got nationally have set out the criteria for who we invite. And when we've got such a robust list of patients that the UK has, it's relatively easy for us to go down those lists and invite those because we've got the right ages and such. And the hospital sites have had a more difficult challenge really to actually establish who they should be targeting, but they've done a sterling job on that. But with the actual booking system themselves, we've actually asked each PCN site what do they think is the easiest way of actually getting patients in volumes into the vaccination sites and getting the jabs in their arms. So quite a lot have gone through their own primary care booking systems of directly contacting patients. There's different areas though within Cheshire have actually adopted, as you've alluded to, more a text-based service. So actually texting patients. Now there was always some anxiety with the initial cohorts, whether that, and I think that system is probably going to be more relevant as we go down the age cohorts. But actually within the cohorts we've utilised at the moment, there's some anxiety that what if patients aren't as tech savvy, are they going to be contacted? And there's certainly a sweep up. So we know that they've got contingency plans within those areas as well. So there's initial texts and then patients can book on. But if they don't pick that up, there's definitely safeguarded plans in place to actually contact patients directly. So yeah, there's different paces in different areas to be honest with you. But actually the good thing about our primary care networks across Cheshire is that they meet regularly and they meet actually weekly within their clinical leads, and those plans are shared and discussed through. So actually each system is modifying itself as we go along and learning from each other, which is I think a crucial thing that needs to happen as well as we go along here. This is acting, as you heard one of the questions, you know, sometimes you've got to Google to find the answer because it was only agreed last night. So we're learning as we go along as well, modifying the systems actually. And I think the question itself will trigger us all as well to figure out, are we actually meeting the needs of patients and how they need to be contacted? So welcome the question. It prompts us all to actually try and meet your expectations too. Thanks, Andy.
Thank you very much. Now, Katie, that was the last of the questions, if no more have come in. I believe there were some questions we received in advance that you might be in a position to read out for us.
I've combined them in the last section, but we have one more question that has recently come in from an attendee that asks, how confident can we be that delaying a second jab will still give a high level of immunity?
So I can answer that, Rebecca. Okay, Gwydion?
There's actually very good data from the sub-trials for the vaccines demonstrating that you get good short-term coverage, and they feel that by giving the second vaccine, and this is for the Pfizer vaccine and also for the AstraZeneca vaccine at 12 weeks, it will either give the same or improved coverage in the longer term. I hope that is a clear answer.
Yeah, so I'll add to that. My understanding is that it was directly studied in the AZ trials that the second dose was given at a number of different points, including at 12 weeks. And so there is direct evidence from the trialing of AZ, I believe, that will work. And then there's an extrapolation to the Pfizer vaccine based on the fact that both of those vaccines are coding for this. It's very technical, coding for the same spike protein, so they're stimulating the immune system in the same way. And as Gwydion says, we know from the Pfizer trial that there was a good response to a single dose up until the point of the end of it studied. They did give the second dose of the Pfizer at 21 days. So, but there is good evidence, good reasons to believe that is the correct way to go. And of course, the reason that it's been done like that is to allow more people to have the first dose of vaccine, which does convey a good degree of immune protection. Not as good as having two, but a very good degree of immune protection. And by doing that, of course, if you give, is it better to give this second dose to somebody to give them a bit more immunity, or to another first person to give them a big chunk of immunity? And that's why that the program is being rolled out in the way that it is being rolled out. Anyone want to add to anything on that? No, Katie, is that the end of our questions?
We've had some more come in. So
right.
I've got I think we've answered this throughout this session, but I think it's probably worth reiterating. We've had a question around specifics. So could a member of the panel confirm the date from which over 60s will be invited for the vaccination? So it might be worth reiterating the timescales and as and when people will move through the cohorts.
So Tracy?
Happy to do so. So just to reiterate, again, the timescales that we're being asked to work to nationally. So by Sunday, all care home residents and carers to have been offered their first dose of vaccination. By the end of January, all frontline health and care staff to have been offered their vaccination. By the 15th of February, priority cohorts 1 to 4 to have been offered the vaccination. And by the 19th of April, all priority groups 1 to 9 would be offered the first dose of vaccination. So the specific answer is by the 19th of April, in answer to the over 60s question. That may change though, as we listen to Boris Johnson and other national announcements on the news and receive guidance. Things may change, but and sometimes things are being brought forward. But at the moment, that's the long stop date that we're working to, and we're on track to do that.
Thank you very much. I realise, Katie, that there are another questions which we'll take. But I'm just going to say to governing body members, we'll come back to governing body to ask further questions after this. So if you just prepare your minds to that. So Katie, you said there was another question.
There is, and it's linked to the immunity and the delay of the second jab. So what happens if a patient can't make 12 weeks? What will happen, and how late can you receive the second dose to be able to get immunity?
Okay, I'll go to the panel. I think I'll say that none of us are experts on immunology, vaccination, or virology. A number of us are clinicians, but we don't claim any special knowledge in these areas. But we can, I'm sure we can give some degree of answer. So, does anyone want to answer that? If not, yeah, Andy.
Yeah, we're just as Andy alludes to, we're going to be waiting for national guidance on this. But actually, a boost, the way that the vaccines have been developed is actually to have a 2-vaccine basis, and the boost can give you better security, really, with developing your immunity, and that is how they've been designed. We are planning, and in all of our planning, we're actually planning for when patients will be getting their second dose as well. So in all our capacity planning, and I think it's important that we do that. It's also important, though, that if you can't get to the date of your second vaccine, there will be contingency plans. We will be planning for that as well. So fear not if you can't get the first date. Getting your second date, there also can be issues, can't there, about being unwell, and you shouldn't receive your vaccine if you are unwell. So there will always be contingency plans for that. So I think it's important that we do plan for the second vaccines, and there will be some flexibility at that point later on in the campaign for you to have it when it's appropriate.
Thank you very much. I think the question was especially about lengthening the dose if you missed your appointment or you couldn't make it.
Yeah, my understanding, the way that the immunity will work and the way that it triggers within the immunity system, it is quite complex, but actually it is a boost to that. A delay of several weeks from certainly some of the experts I've seen won't delay that. It will just boost your immunity further. So say a delay of 2 or 3 weeks, it shouldn't have that impact. What we don't know, I mean, quite frankly, what we don't know is the evidence base is of what happens to your immunity in that meantime. The AZ vaccine is clearer. We've got quite clear evidence that 12-week is an appropriate one, and actually delaying that time, you get better immunity from delaying within the AZ vaccine. So we're confident with the AZ vaccine. It's clear in the Pfizer vaccine that there's been less science behind that, although that is ongoing. And as we speak, there are trials ongoing looking at immunity levels within the Pfizer vaccine from 1 dose. So nothing that I've seen so far has seen that immunity has fallen off a cliff, is what we've been hearing, what the anxiety is. So delaying the second vaccine, we're not anticipating that is going to actually see us drop our immunity levels down rapidly. It's only going to boost the initial vaccination.
Thank you very much. Right, I am going to turn now to governing body colleagues to see whether there's any further comments, questions within the governing body before we return to Katie to see whether any further questions are coming from members of the public whilst we do that. So, Mike.
Thanks, Chair. On that last point, I think the main take-home message there is if you do have to delay, the most important thing is just get your booster done, whether that's at 13, 14, 15 weeks, just get your booster to build up your immunity. And the other point I just wanted to quickly make, following on from one of the previous questions, is If somebody is acutely unwell and can't come for the vaccine, and if that's because you have COVID symptoms, do not come to the clinic. So we would want to make sure people don't come to the clinic for the vaccine if they've got COVID symptoms. And on the same vein, we wouldn't want people being patients at home when they are isolating because they've got COVID symptoms just to give them the vaccine. So I just wanted to make that point. We can rearrange it for another time, so you won't miss out, but just we don't want to be vaccinating you when you're acutely unwell with COVID symptoms.
And there is a time lag, isn't there, between testing positive for COVID and being able to have the vaccine, which is 4 weeks. Any further questions from the governing body members? No. Okay. So, Katie, I will come to you for any last questions that have appeared from members of the public.
Thank you, Dr. Wilson. We actually have 2 final questions from members of the public. So the first is a question around requesting priority vaccinations for support group volunteer drivers who provide transport to and from medical appointments, including vaccinations. Is this possible, and how do people go about it?
So, Tracy. Thank you.
We have set up a central, email address that is for frontline health and care staff. So anybody who thinks that they may fit that green book definition, and if you look in the papers that we've provided, it gives a link to that, then please get in touch with that email address and we will work with you. That's not making any promises, that's saying that that's the way to handle that inquiry, and that also goes for others who think that they may fit with that frontline health and care staff definition. It is quite wide and it's been set again nationally, and that's how we're applying it. So that would be my suggestion. And then we are working with our providers to find opportunities for people to receive the vaccination, particularly with our hospital hubs, the 4 hospital hubs across Cheshire, working through that list. So before the session ends, I will give you the email address as well, but that would be my suggestion for that particular question.
Thank you very much. Katie, you said there was a final question.
And one final question that's come in. It's quite specific, but I think it's an example that a couple of people have asked over recent weeks. So my husband has had his letter calling in for his vaccine as he's 82, but I'm 79. Does it not make sense for us to go for our vaccine together?
Is anybody in a position to answer that one? I think the answer is probably yes, but Dr. Clark.
A simple answer from a practical point of view for delivering vaccine is yes, particularly if you have to come with that individual because you are their transport. It's easier if you're just one cohort down. If you're much younger, it's harder to justify, but yes, it does make sense, and in practice that is what we're invariably doing.
I'm just looking around at other members of the panel. If you breaking, so Dr. McAlvey.
Yeah, I mean, I can go with Mike, to be perfect, Dr. Clark. We've had these discussions about what you do and whether you should be inviting couples to the vaccination, go in alphabetical order. So there's lots of logistical things we've been thinking through about how to do this in a common sense way. Avoiding, exposure to the, being outside for those at-risk populations. So I think the sensible answer is the one that Mike's offered, to be perfectly honest with you. And I discussed that with, if you go into a primary care network site, discuss that with whoever's arranging your appointments. Frankly, I think as the cohorts, as we're going down the age cohorts now, and it's quite acceptable to be going into the over 75s and over 70s, I'd be very surprised if you had somebody who's declining a 79-year-old patient from receiving the vaccine. Very surprised.
Where did you want to come in?
The national guidance changed on that a couple of days ago. So previously it was quite prescriptive for whoever that was delivering the vaccine to, for example, start with group 1, then group 2, then group 3, then group 4. Whereas now there is a loosening of the restrictions so that if you are in the top 4 groups and that centre has capacity, they can make those allowances, which would apply to that question.
Yeah. Thank you. That's very helpful. Right, I think I think that's the end of our questions. Thank you very much to Katie for the work you've done behind the scenes. Oh, Andy, do you want to come in?
Do you mind if I just say something, Andy, just very briefly? Is one of the questions I was hoping to be asked is, can I change my behaviour after receiving my first dose? You know, it's something that I think patients would want to ask, or certainly would want to know about. And my advice really is I'd behave exactly as if I hadn't received the vaccine yet. There's still, you know, I would, you know, I'm delighted that thousands and thousands of patients in Cheshire are actually receiving their vaccine. It's brilliant, but it limits the amount of illness that you get. It would limit the need for you to be hospitalised with COVID vaccine. It doesn't offer you 100% immunity. Okay, so there are still limits on that, and also it doesn't actually stop you from possibly catching it and passing it on to somebody else. So we don't have the evidence base that it reduces transmission yet. So I'm delighted that patients are getting it. It will reduce your chances of getting severely ill with COVID-19, but for the reasons I've explained, I wouldn't change your behaviour just yet unless we get a lot more confidence and thousands of millions more people vaccinated.
Thank you. It's very worthwhile bringing that up, and certainly I've been saying to patients, this doesn't do anything for you instantly, because I didn't want people suddenly sort of running off and booking children's parties with their grandchildren, thinking that they were protected, because it doesn't give you any protection immediately. All has to build it, doesn't it? And then all the caveats that Andy has just explained. So that's thank you, and it's a really good question to ask. So I think that it does bring us to the end of the questions, but I think Matthew has got something he wants to bring up. So Matthew, do you want to come in, please?
Thank you, Andrew. Hello, Matthew Cunningham, I'm Director of Governance and Corporate Development, and luckily under my sort of portfolio, I've got comms and engagement. So I just wanted to put a couple of thanks out, really. One, we've had an absolutely tremendous response from the Cheshire population to get involved and volunteer with the vaccination programme. So I really want to express a great deal of thanks to everyone who's put their name forward. We set up our own sort of volunteer sort of bank, which does both clinical and sort of administrative and marshals, and we've had over 1,200 people sign up for that. So a key message is, one, thank you for volunteering, and two, but equally be patient as we work through all the applications, all the paperwork to try and get to you, to then hopefully enable you to be able to volunteer at the various different sites. And I'm sure our GPs and others on the governing body would also like to thank all the volunteers who've helped, because without you we probably wouldn't have been able to do what we've been able to do across all these various sites. Going forward, the Royal Voluntary Service is also the main place for people to go to sign up to volunteer. So it's a national site, and so far we've had over 600 people from Cheshire put their name forward to there and there. So it's just a really great testament to the people of Cheshire wanting to do their bit towards the vaccination programme. And I think that also sort of mirrors the fact that I think our Cheshire population have been really good at listening to the advice around staying safe and shielding, and that absolutely helped us all to deliver the vaccination programme and support each other to get through COVID. So again, thank you for that one. My last plug, Andrew, is that as a CCG, we try and keep our website as up to date as possible with all the information for members of the public regarding the COVID-19 and vaccines. So we are trying to encourage people to always go to, in effect, our website, which is cheshireccd.nhs.uk, and we'll keep that up to date as much as possible. So some of the things you've raised today, we'll try and reflect that in the web content, but please keep going back to that to keep that up to date. And our partners across Cheshire are also linking into that to try and replicate that message, so everyone can find the same information wherever they look. I'll leave it at that. Thank you, Andy.
Lovely. Thank you very much. And that just, I think, bring us to the close of our meeting. So I'd like to say some thank you to the panel, particularly thank you to Rod for joining us and very helpful input. And thank you to all of those people that have joined the webinar and asked us questions. It's great to have that interest and scrutiny from the public. So thank you very much for taking the time to do that. And I hope that we have answered your questions as well as we have been able. But we are open to questions. So please do, if you have questions outside of this, then please do ask them, and we can collect them and put them onto the website, because others, if you think of it, others will be asking the same question as well. So thank you very much for everybody for the session today. I think it has been a great session. It's been great to be able to talk about the vaccination programme and how it's rolling out. It is a great beacon of hope for us. But I will once again remind people that we are, as it stands, still in the middle of a peak of COVID-19. Please continue to follow the regulations, continue to be safe, and I hope everybody has a good day. I'll see you at the next governing body. Thank you.
Thank you.